Hey, this is Dr. Peavler. Was Paige?
Hey, Dr. Peavler, you're the hospitalist on the night.
That's right.
All right, Dr. David Lee, I'm the emergency physician down here, taking care of a woman, 87 years old, could really use your help tonight.
Okay.
Family brought her in by private vehicle with primary chief complaint that she's just had failure to thrive at home. I'd say the last couple of weeks, they said that she's not really taking in her normal nutrition, has also had repeated falls, but no catastrophic event just yet. She resides at home. She's alert and oriented, times four with her also elderly husband as well. No new changes to her medications or illness, injury recently that they can recall, but they just feel like she's had a very slow decline in her physical health. Mentally, she's still pretty sharp and converses with them just fine. Anyhow, I did a pretty comprehensive workup down here. Got blood work, EKG, urine on her, scanned her head even just to make sure there wasn't anything acute going on. And I'll be honest with you, just right up front, there really isn't anything acute that I can find. She does have a little bit of an acute kidney injury, I think, with a creatinine that's slightly bumped, but that might just be because of her poor oral intake more recently. Otherwise, her head CT is just fine. Blood work looks all, basically baseline, maybe with a lower limit of normal um, sodium of 133 today. But otherwise, okay. And I'd say if it wasn't in the middle of the night, I'd try to my very best to try to get this patient, dispositioned elsewhere outside the hospital. But the family's insistent. They're very concerned that she's not going to do well if I send her home. They don't feel safe for her there. So I really have my hands tied here because I just don't have a good place to send her. So I wanted to see if we could bring her in for truly a social
I
admission
found them
here.
on the system here. So I mean, I'm looking over everything. I mean, yeah, the EKG looks good. The urine looks good. Labs, like you said, the sodium is mildly low. I mean, generally, I don't like. I mean, there's really no criteria for admission with the sodium above 130. So that's going to be a tough one to sell. Her creatinine, I'm looking back at prior records. It looks like she's pretty much at her baseline. Probably has some mild CKD. I don't know if it's documented in her records. Um, CT looks good. It looks like the radiology read came through because he ordered a stat. Thank goodness. So man, this is a tough one because there's just no reason, unfortunately, to bring this lady into the hospital. She does not meet criteria for admission. There's no
Yeah.
question for that. It's just, maybe we could call it like an adult failure to thrive type of thing. Hyponatremia, mild. I think she's unfortunately, this is where it gets difficult for us. It makes it easier for the family. It makes it easy for you to get, the patient out of the ER. But once they get to the floor, they're basically in the hospital for no reason. They don't meet criteria for admission. So therefore they're going to be in an observation status, which means they're going to have to come out with a significant money out of pocket, which sucks for them. And I'm not really doing much for her here. Now, that being said, we will get a physical therapy and occupational therapy, evaluation. Just like you guys don't have case managers over at night, we don't have a lot on the weekends. So, it's going to be tough to get her out of here tomorrow. I think it's going to be a minimum Monday. And I hope that we can finagle something to get her into like a skilled nursing. But it sounds like the family needs to have that difficult conversation of where does she go after all this is over with. It sounds like she's not safe to be at home.
Yep. Yeah, I wholeheartedly agree with you. I did have a pretty frank conversation with the family to say that, this is primarily an issue of, long-term assisted care, which they're all kind of just embarking on right now and could use whatever resources you have available,
Yeah.
unfortunately. So yeah, if you could help us out tonight, bringing her in, I know it's a little bit of a soft admission here, being that she doesn't really meet clear criteria to be admitted. But our my primary concern is just with her repeated falls, though she doesn't have anything acute tonight. Boy, if I send her home and we see her back tomorrow night or the next day, something
Yeah, I
having
mean, there's
broken her
obviously
hip,
pros and cons. I
yeah,
mean, like we
hmm
obviously we don't want to get her exposed to some nasty bug, like
right,
a hospital-acquired infection, or God forbid, have her acquire some kind of a delirious process which prolongs hospital stay.
yeah,
But yeah, I think we bring her in for kind of adult failure to thrive, hyponatremia. and we get her evaluated by the therapists and see if our case managers can help do something, whether it be get community resources or get her into a skilled nursing, maybe, to
Right.
get her some PT, but it sounds like I said, long term, that's not going to be a solution for them.
All right. I'll go ahead and communicate then down here to the team that we're gonna probably put her up in observation with
Yeah,
you.
yeah. I'll put the order in a couple minutes.
All
Just
right.
tell the family that they'll be going upstairs whenever we get to bed.
All right. Thanks, Dr.
All right.
Peavler.
Yep, no problem, man.
All right. Take care. All right.
So how often do you get that scenario play out in the ER where you worked, or the ERs where
Oh
you worked?
goodness. When I'm working, particularly in the hospitals, that may be the primary referral sites for a lot of these skilled nursing or assisted living facilities. It's on a very regular basis. We see these patients that uh, you know coming from the home, particularly, it's that very much that story, and I hate to be crass about it, but it's almost as though the family members that bring them in frustrated hope that we find something acute
Right.
to almost alleviate
Yeah,
them from
as
having.
respite.
Yeah. And I can't blame them. I mean, that's a
Right.
hard responsibility, trying to take care of an elderly loved one that isn't 100% independent at home, but on a very regular basis. Yeah, I'd say on a
Yeah,
shift.
me too. I would say at least minimum once per shift.
Yeah.
Um, I get this call, and it's really hard because obviously you want to help people, you want people to be safe, but at the same time, like, you can't admit people to the hospital that don't need admitted. That actually reflects poorly on us. It increases our hospital census, and it makes it kind of unmanageable sometimes, especially during flu season, cold season, et cetera, when you're already at kind of max capacity. So it really does strain the system a lot when there's no need for hospitalization. And like kind of we touched on during the discussion earlier. You can get hospital acquired infections, you can get delirious, which increases your risk for death, mortality. So, and it's so easy to get confused in the hospital, from sundowning and so on and so forth. So yeah, I mean, it really is not the best. It's like, there's pros of, we don't want the patient to be in an unsafe situation, but at the same time, there's definitely plenty of cons.
So I think we kind of discussed how making this video, you know, vlogging basically our experience, because you and I, unfortunately have a front row seat of seeing this.
Right.
Myself working in the emergency rooms, and you're admitting these patients basically to the hospital, and because we've been working together and been real good friends over the years, just kind of ironed out our frustrations with it. And I recall having a very excited discussion with you, because one of the big hospital groups that I worked for eventually established a relationship with uh, a skilled nursing and assisted senior care facility, where they were able to provide at least my emergency department a assessor, one of these folks that they dispatch 24 hours a day for us after we've cleared them of any acute injury or illness in the
Right.
emergency department. They'd come and basically try to determine the patient's level of care required, and sort of go through funding and some other issues to find the most appropriate patient for these placements for these patients. And that was just a tremendous resource for me, because no longer did I have to have a very difficult conversation when trying to admit these patients up to the hospital. But also, it doesn't feel real good for me to have to send many of these patients home, because I know they're just not going to do real well, and
Right.
helps to alleviate all the stress from the families that are also
At least for a couple of days.
yeah, absolutely. So, in seeing that, I thought to myself, well, that there's certainly a need here, because when you ask the family members, have you not considered putting your, mom or dad in a nursing home, that they almost kind of, we don't, we had discussions about that, and mom just doesn't want to go to a nursing home. We were instructed, or we agreed that we were going to try to take care of them to the best of our abilities, and and they're trying their darndest, and so I find that there are many in this generation that just don't want to go to that sterile big nursing home complex where you're just another body in there,
Right.
and
Number.
yeah, and another number. And I see many of those patients, unfortunately, going to a nursing home isn't the solution that they're looking for. I see many of those well-to-do patients that succumb from, urinary tract infections or bed ulcers, or,
Right.
just
Upper
overall.
respiratory infections that kind of go around the
Exactly.
facilities and stuff like
Right.
that.
And you see a lot of that, right? Many of these nosocomial infections that just kind of run rampant in
Right.
the
And not to mention the
group
drug
homes.
resistant organisms,
Yep.
unfortunately.
So that's when we kind of brainstormed a bit and kind of embarked and heard about the Homes Plus, kind of a novel idea to senior care, in that you're able to establish, um, nursing home level care in a
Right.
private residential home. I thought that was just a very unique idea that, after mulling on it a while, thought, that'd be exactly what I'd look for. If I were needing help myself, um, you know, the last place I think I'd want to go is to a large nursing home. But if I could have the assurances of that quality of care in a private residential home, kind of with a little bit more of a intimate kind of personal care attendance, I think that'd be exactly what I'd be looking for.
Yeah, for sure. I don't know if you remember or not, but I think what got me was actually when I was in residency, and I had all these folks that had retired to Florida from New York, New Jersey, Boston, et cetera. Um, and they were doing well for 5, 10, maybe 15 years. Then they started to have issues, and the family members that were able to would come down to Florida to help, care for their loved ones. But a lot of times, because of financial reasons, they had to work during the day. And they would just say, what can I do with my loved one during the day when I work? I can't take care of them. They can't take care of themselves. So we would look into, like, through the social workers, we would be looking into, 24-hour aides basically. And that was, ended up being like more than $10,000 a month, which for most of these people, they couldn't afford, And so I had learned about in residency something called adult daycare, which is what got me onto this actually. And we looked into doing adult daycare, which Providence does offer adult daycare, but really the Homes Plus model was even the better one, because it was people who needed to be in a nursing home, who really needed that care, but really, like you said, didn't want to go into a big facility, wanted to be in more of a homey environment. The ratio of people, staff to residents is way better, like 4 times better. And just more activities, more freedom to do what you want, and less likely to have a bad outcome, with delirium and stuff like that, because they're in their own, that's their home,
Sure.
and they consider it
And
their
not
home.
not not to badmouth that other
No,
industry,
by
but
all means.
you can't imagine the amount of times I see patients brought in by ambulance from a nursing home somewhere, you know, because of fever, or, maybe they're acutely agitated, and I have no ability to contact anyone in the home that knows anything about this patient. Somebody, I think, overnight stuck a thermometer to the patient, or at least was keen enough to notice that the patient had something awry, right? And what did they do? They called 911. An ambulance
Right.
came to pick them up, and that was that. For them, that's probably all they need to do, right? That's probably more than that they were expecting to do. Just being able to get that resident into the right hands. So frustrating though on my end, because I can't get any information as to health
Right.
history, what medications they're on, what was the
Everything labs
inciting event.
normal.
I have no idea, right?
Yeah.
And so I'm stuck, basically uh, doing a pretty comprehensive workup to make sure that there's, nothing life-threatening of illness or injury, and then after that, communicating up to the hospital folks, yourself, with really not a very good history, and I feel terrible about it. But that's the nature of
Right.
my work, is that, like I said, the folks that are coming from the nursing home, sometimes I'm sure many of them get very good care, but too many times I see that, they're kind of just, lost in the midst of maybe the sheer amount of residents that are, being looked after by minimal staff, perhaps even overnight, that there really isn't a personal feel or understanding, as opposed to, what I have grown to learn about the Homes Plus model, in that we
Right.
know very in very detailed in a very detailed manner the health history and composition of our residents and
Right.
patients, so that.
Well, I mean, it's like you said, it's not really knocking them. It's just that, when you have 16 patients versus 4, you're obviously going to have a more intimate relationship with those people, and you're going to know more. It's just, that's just the nature of it, I'm the same way, man. I end up, after you probably have failed once or twice trying to get a hold of the nursing home, I'll probably end up calling myself, and, you know, maybe I'll find the nurse who's taking care of the patient, but they don't really know anything and they really can't tell me. And, they didn't, the aide that was taking care of the patient who found the fever or found the ultramental status or whatever it is, like, is off, they're gone. Their shift is over with. Like, no one knows what medications they were on last. Like, they don't even know when the last time they were normal. It's just, it makes it very hard to take care of patients in a hospital setting for even for acute illness, when we have a reason to bring someone in the hospital because of that reason, and I think that this model, um, I mean, it's about as good as having your family take care of them, because it's that tight knit of a situation, in
Sure.
that model of care.